So very good morning to all, dear friends, respected seniors and colleagues. There are joint replacement giants sitting on the dais and most of them are robotic stalwarts, and I am given this topic. They have written in the brochure that I do not need because, but actually a little bit more sophisticated title is, do we really need robo for TKR? And what I have changed it to, do we really need robo for all the TKR? So there is a rapid rise in the robotic systems in arthroplasty. There is always marketing versus medicine, technology evolution versus outcome improvement. So what robotics, why robotics? There was 10 to 12% deficit in the dream for forgotten knee, even with picture perfect X-ray. The belief that if we bring measurable accuracy to alignment and bone cuts, it will help achieve this dream. Robotics give us radiographic accuracy. We have seen a lot of degrees, this. Better mechanical alignment, improved coronal and sagittal accuracy, better and consistent component positioning. But does radiographic accuracy always translate to clinical benefit? Let us see the evidences. There are lots of articles available. I'll take some of them and a bit fast. 2018 study, robotic technology in GBGS. Ranawat award-winning study with 296 TKs with 15 years follow-up with conclusion of did not differ for function. Another meta-analysis done by Dr. Arun Mullaji sir said limited evidence that CSTK improves functional outcome at 5 to 8 year follow-up. A retrospective study, a prospective study with 1100 knees, all demonstrated that there is minimal clinically important difference. The trends in USA in 2019 was, there was sparse use, there was increase, but it was hardly from 0.2% to 1.2%. Still only 1% of the arthroplasties are done by robots. Less than 3% of the surgeons used robots, and 40% of the surgeons didn't use even when their institute were equipped. Some recent articles, World Experts Meeting done in Istanbul, conclusion was does not show clear benefits in terms of functional outcome. Another meta-analysis with 1942 knees, conclusion was superior post-operative anatomical and mechanical alignment, but similar clinical and functional outcome and complication rates. Annual general meeting of AOS concluded there is no difference in the risk of revision when they saw for 9,000 plus cases, and the findings were in line with Australian registry. CORR 2025 suggested not able to find any meaningful differences. Umbrella review of April 2025 with 10 systematic reviews included, large database included, again suggested that it improves alignment accuracy and may reduce hospital stay, but does not support consistent advantages in the long-term functional outcome and pain relief and even revision rates. Another very recent one, done over 2 decades, suggested superiority remains inconclusive. And one very important done from one of the masters of joint replacement, Dr. Javed Parvezi sir. The title itself suggests that robotics, real innovation or a marketing ruse. The words of wisdom from sir was, with survivorship of arthroplasty approaching 98% at 10 years and 95% at 20 years, any innovation must clear a high bar. Much of the today's innovation is fostered by industry rather than by academia. We are not Luddites. We embrace innovation. When robotics will be proven truly beneficial and cost effective, the rewards would be substantial. So, metrically fixated fail to realize that there are things that can be measured. There are things worth measuring. But what can be measured is not always worth measuring. And the cost of measuring may be greater than the benefits of measuring. So not always behind angles. So what is the FDA approval status? It's all are 510K cleared, means substantial equivalence to existing device, similar intended use, similar technology and safety profile. But none of the robot has undergone full FDA pre-market approval with mandatory large clinical trials showing superior patient outcome with long-term studies. PMJY knees, almost 1.6 lakhs knees done till late 2025. No robots were used. Does it mean that there was less success to the surgeons and less happy patients? Insurance companies are giving 1 lakh rupee per knee at present, encourage many to buy robots or justify to purchase it with cost-benefit ratio. But suppose if in coming time with all these evidences, if insurance companies to stop giving any extra perk for robotics, would we still buy robots worth crores? What do we want from practice? Good X-ray, good function, or both? Patients want good function. We are obsessed with good post-op X-rays, but what matters is happy patient. The one comes for the second knee, the one brings another patient for knee. Let's see some results. The 55-60-year gentleman was operated for bilateral knee. Another lady was operated for bilateral knee and is now doing Garba very nicely. Another lady operated for bilateral knee. From all these three patients walking very nicely and having wonderful results, is it possible to tell which one is robotic TK, which one is conventional TK, and which one is conventional with PMJY? It's really tough. One can say from the implant, but not from the walk. It's not going down. Oh. There are two couples, 8 knees of the same family. All were operated one by one. All were happy. Another THR. Results of THR. So that was also happy patients doing all their work and back to work, doing masonry work, farming and dancing. The conclusion is alignment accuracy and implant positioning is better with robotics. Complex anatomy and pre-existing implants, robotics may be better. Functional outcome is similar. Long-term survivorship is similar. Complication rates are similar. Soft tissue feel and dynamic observations are better with surgeons in terms of ligamentous tension, balancing, particularly patellofemoral tracking, subtle instabilities, unexpected bone defects. There is a long operative time for extra steps, pins in some systems, also increases the risk for stress riser. There is a learning curve dependent on the data input we have seen from the morning. And you can't do that, आलू डालोगे तो सोना निकलेगा. It's not like that. आलू डालोगे तो आलू ही निकलेगा. High capital investment with quite high AMC, trained support staff is required, pre-op CT required. In turn, raise ethical concerns. Hospitals may feel pressure to increase robotic use for financial viability. Surgery is dynamic and not algorithmic. Robots follow pre-planned algorithms, executes a plan, while surgeon makes the plan. So experience remains irreplaceable. Technology may assist surgery, but it does not replace surgical wisdom. So robotics, good business strategy, no doubt about it, not harmful at all, nothing wrong to use for marketing, good for few specific situations, but no extra benefits over conventional in most of the parameters seen as in the literature. So should not be promoted as standard of care until cost-benefit ratio is well established with better functional outcomes in literature. Thank you.